Great. So Catriona, can I start with you, please, and ask you to remind us just why it is so important to put a spotlight on women and heart disease, even though both men and women do have heart attacks? What's the difference for women? What are the signs and symptoms? What should they be looking out for, and so on?
Hello. So I'd like to say that the signs and symptoms aren't necessarily so very different from what men experience, but women may not experience them in such a prominent way. And so then they don't get so easily recognized, and they don't necessarily present in a timely manner. They're more likely to present later and therefore have a poorer prognosis. And we do know that older women, do have heart failure from probably because they've had heart disease that hasn't necessarily been recognized and treated in a timely enough manner. So that is why it is so important that we alert women to the risks they have for getting heart disease, just in the same way as we do for men.
And is it different for women, though, in terms of how they present for a heart attack? Is that very different or not very different?
It's not so much that it's different. It's just that it's like our other two experts probably have more to say about this. But for example, men, the classic symptom is the crushing heart pain, and maybe the chest pain for women maybe isn't quite so dramatic as it is for man, but nevertheless, it is a real symptom and needs to be dealt with.
Okay. And Eva, could I come to you and just ask you, you're in general practice, and what do you experience on a daily, weekly basis when you're seeing women? Do you get a sense that they are aware that they should be, as you know, that they know enough about their risk factors for cardiovascular disease and how to manage them? Are they as aware as they should be?
I think possibly not. The main risk factors of being overweight, obesity, high blood sugars, diabetes, blood pressure, cholesterol, and alcohol intake, it's not always obvious to people, and sometimes people don't put the full picture together within their lifestyle choices and how it how they all relate to each other, and it just increases your risk of heart disease over time. And yeah, so it's definitely something I was going to say as an Irish community, but it's not okay to say that because it's diverse now with lots of different backgrounds. But it's just really making choices for your health that really aren't very mindful at all, and it's causing problems, and we're not aware that the implications of certain food choices are not looking after your blood pressure, not looking after your cholesterol, the impact that's having over time on our bodies and our heart.
And are you seeing that coming to fruition now in your practice? The fallout from not having had that education over time, or people not being as aware as they should be.
Yeah, and I think something which is what we've just come out of, the 2 years of the pandemic, and we were at home for a lot of that time, so maybe we let ourselves off with things, and now it's like maybe we can see the changes that have happened.
Yeah. And do you think we talk enough about heart disease generally?
I think
in women, I should say.
Well,
heart disease generally and in women, yeah.
I think we do to a certain extent, but it's to maybe come to a point where somebody decides to make the changes that I want to change things in my life.
Yeah.
Yeah.
Okay.
Thank you for that. And Mary.
Sorry. No.
Yes, you want to say something? Mm-hmm.
No, I'll let Mary go. Sorry.
Sorry. No, Catriona, go ahead. Finish off the point. Yeah.
Yeah. So no, I was just going to say that, of course, all those risk factors, the high blood pressure getting higher, and putting on weight, and becoming closer to getting diabetes, having dysglycemia, and of course dyslipidemia as well, so lipid problems, those all become much more apparent at the time of the menopause. And so it is a real priority for women to look after themselves and look after their lifestyles, which will of course impact on their cardiovascular risk and reduce their risk of a heart attack. But this is about raising awareness and also providing really good interdisciplinary support to do that.
Mm-hmm.
That's a good point. Yeah, the interdisciplinary element of it, and we'll come back to all of those points as we move through the session. Mary, I'd just like to come to you as well, just kind of on the whole area of women's health. I've heard recently that healthcare professionals should not be seeing women postmenopausal just for the very first time to assess their cardiovascular risk. They should be taking opportunities much earlier in their lives to engage on this. And you talk a lot about empowering women, to know the facts and get educated about their health. Can you expand a little bit on why it's so important in relation to cardiovascular health that women might do this for themselves, they advocate for themselves in relation to this?
Absolutely. Well, I was involved with the Irish Heart Foundation, and still am, on talking about the women with heart disease. And the reason for it is that, because I see a lot of women in their 50s getting heart attacks. And I saw, and they started this 7 years ago, and I saw that, we talk a lot about breast cancer, but in actual fact, the heart disease is the #1 killer, as you said in your opening statement, and people don't realize that for women, heart disease is actually the #1 killer. And as the other speakers were saying, what happens with lower estrogen, the fact that women coming into menopause get weight around their tummy, so therefore they're going to get lower the good cholesterol, up the bad cholesterol, okay? So they're basically getting all of the things that will create plaque in the artery and cause heart disease. But this is not widely known, and we have done a fantastic job in empowering men and telling them about heart disease, but we didn't do that for women. And I think we wrongly focused on a lot of the symptoms of heart disease, but didn't say the other things that happen with menopause, one of which is heart disease. So I think it's all about education, empowering women to tell them, listen, it's not just about, the flushing and the sweating, it's also about the risk of heart disease. And you do, because once you lose estrogen, you put weight up around the tummy. We call it in endocrinology metabolic syndrome, which basically means those fat cells around the tummy they're really active endocrine organs. They produce really bad hormones that attack the arteries. And, women are at risk of heart disease, and it's for women to know this so that they control the blood pressure, they check their lipids, make sure the lipids are normal, total cholesterol is under 5, the bad cholesterol is low, that they give up smoking if they're smokers, and that they keep their weight normal. So I suppose it's about, educating women. We've done a great work on breast cancer, but we haven't empowered women enough on heart disease and saying that, this is actually the #1 killer in women, and that we need to do this. And I think someone else asked the question about presentation of heart disease is different in women. So while we all know that, chest pain and exertion, but women can often present differently, just with fatigue, with shortness of breath. And these can be symptoms of it, and you need to be thinking heart disease, because we see too many women after having heart attacks in coronary care, and they're all in their early 50s, and I'm thinking, why didn't, we need to do more prevention. So I think we've done amazing work with menopause, we've done amazing work with breast cancer, but we need to do more on women with heart disease, and that really is an education, and what we're doing here tonight is great, because we're putting it out there that women have to be also focused on heart disease, and it's actually the #1 killer, and we're probably not getting that message out to women, so that when they're fatigued and tired, they're thinking, I need to get my heart checked as well. I think that's very, very important. And just very quickly, so I won't forget it, diabetes, believe it or not, brings on menopause. And this is something, there's huge research coming on this now as well. And obviously we know diabetes, 3/4 of them with type 2 diabetes get heart disease. So I suppose it's just to make people aware that putting on weight around the tummy, which happens with low estrogen, puts you at risk of diabetes, and diabeetis in itself can bring on menopause. It accelerates.
That's interesting. I didn't know that.
Yeah, absolutely. Huge research on that now at the moment. Yeah.
Hey, thank you for that,
I suppose we
Mary.
really have to educate women on that, and just tell them to make sure, and obviously make sure that they come to their GPs and get all these things checked, as well as educating them about osteoporosis and all the other things that we do. So it's about empowering them with the knowledge so they can present to their GPs and you know, not put themselves last as they often do, and come and look after themselves, because menopause is their second chapter, it's their second spring. It's to be viewed in a very positive light. Should have all, if they live like the Queen, they'll have another 46 years to live. So therefore, we want them to be healthy years. And you know, it's up to us as medics to empower women and to say, look, it's time for you to look after yourself. This is your second chapter. Now's your time, and just make sure it's all about prevention and living a really healthy life as best as you can.
Absolutely, that's brilliant. Yes, sorry, Catriona, go ahead.
No, I was going to say, and of course, this isn't always something that you can do on your own. So, for example, with smoking, you need help. Most people need help, especially if they've been smoking for a long time. They need help and support to actually give up smoking. Equally, they need education about healthy diets and cardioprotective diets, but it's about really getting help and counselling to make those changes that are going to make such a difference to your cardiovascular health. And same with physical activity and weight management, of course, which is a real challenge.
Especially for women in menopause, it's really tough because your metabolism has completely crashed, and people don't realize that you've got to change, you know, reduce the amount that you eat, or eat more healthily. You got away with eating unhealthily before that, but now you have to change and really stick to the healthy eating. So
and I guess in talking about this as well, and you spoke about support there, Catriona, and just the whole conversation has shifted so much in Ireland at the moment about menopause, and just the awareness of it in itself, and now putting it together with heart disease. It's also important that, I suppose, that men and, you know, everybody knows about it. It's not just for, you know, so that there can be support out there for women, for your mother, for your wife, you know, for your sister.
Yeah,
and
totally.
especially as it's always been such a taboo subject. You know, we don't talk about menopause. You know, men and women don't necessarily want to hear it talked about because it's embarrassing or whatever. And actually, that makes it really challenging for women who are going through the menopause.
I think we've changed that a bit, Catriona, because we started talking menopause nonstop for the last 2 years. So I think we're changing that, you know.
Definitely it's changing. Yeah, absolutely.
Yeah. I think one of the best things was that I actually was asked to go on Joe Duffy's program, and I was a bit reticent about going on because, you know, I didn't know what the frame was like, but I was delighted when I heard that the whole week was led to talking menopause. And it really showed that women, because all of us have seen women that, you know, suffered into their, you know, they're now in their 70s and 80s, and they just went, you know, went through all the phases and really ignorant of all the things they could do. But they all came up and sort of said, you know, why did we have to suffer? And what was lovely was you now have all women coming out, and it's really empowering to see women coming and saying, hang on here, we want to be treated. We now have the menopause hub clinics, we have Eva, you know, very involved, all GPs involved. It's absolutely wonderful. And men actually want to know about it. The partners want to know about it. The spouses want to know about it. And after being on Joe Duffy, one of the patients came in to me and he said, Dr. Ryan, you know, he was 84, and he said, I feel terrible. He said, I didn't realize what my poor wife went through, you know. So it was, so you know, it's good to educate the spouses, the partners. It's good to have to bring it out into the open and have a full week on a radio show like that, because really everyone got educated, and that's what we're all about. And it's taken away the stigma as well. And it should never have been there in the first place. It's there since Adam and Eve, you know.
It was something good also that came out of the pandemic time, because that really changed consultations in general practice. We had you know, so many women come in, and I know that it certainly did help, you know, really accelerate awareness of menopause. But even though that movement has happened, I still see a certain group coming into me, and unless I start to speak to them about, you know, the menopause, they sometimes leave it unspoken and they suffer in silence. And there's this idea, when I talk to them a little bit more, they can admit to feeling sometimes invisible in this stage of their life as a woman, because maybe their children are reared, they're married, or maybe they're separated, they have a role working, or maybe, you know, they don't work outside the home, but they don't know where they're, you know, they don't feel happy in themselves. And there's this idea of feeling, where's my place? And it's to try and as Mary said there, you know, after menopause, you know, given our life expectancy in Ireland, we're going to be living a third of our lives postmenopausally. So you want to be able to offer good health care for that woman, and she deserves it, but also it's there.
Yeah, exactly. And on that note then, Eva, maybe we might move into just digging in a little bit more into the risk factors and, you know, menopause, and the fact that having risk factors for cardiovascular issues such as diet, high in fat, smoking, pre-existing conditions will all increase the risk of developing heart disease as you go through the menopause transition. And so maybe you guys might talk a little bit about that.
Yeah. Absolutely. Well, this was the big thing is the diet, you know, because women in menopause, your metabolism really crashes and it slows down, and you're more likely, because of low estrogen, you're more likely to put on weight. The key thing is women is you have to eat healthily. It's like somebody who has suffered from overactive thyroid and you normalize their thyroid. They might have got away with eating unhealthily up to that, but really now you have to stick to eating healthily. So your 3 healthy meals and your 2 snacks. And really cut your processed food and your caffeine, and alcohol has to be moderation, because caffeine will stimulate a lot of the flushing and the sweating. But in particular, we advise, you know, good healthy food, and in particular, cut your sugar intake, because this is what's going to increase fat intake. So we try and advocate, and the dietitians would advocate healthy eating as opposed to talking about dieting. I think we're now focused more on healthy eating, on exercise, and getting the whole family to eat healthily. So we would often have this conversation with, you know, we're asking them to cut down on confectionaries, that it has to start with the shopping trolley, and therefore they're not brought into the house, and then just one decent treat on a Sunday and maybe 2 squares of 85% dark chocolate every other day. So I think we're trying to say to women, you know, it's not that we're going to make you suffer, we're going to make the whole family eat healthily. You're probably the one that does the shopping, and you don't buy any sweet things, which will be a temptation for you, because around menopause you're very tired, you're fatigued, and you are inclined to carb crave. So don't have temptation there for you. And then on the Sunday have the treat. So we're trying to do it as where we can get the whole family to eat healthily. But it's critical that women don't put on weight, because if you put on weight, which they always put on weight if they're going to put on weight around their abdomen, that increases your risk of heart disease. It increases your risk of diabetes, and diabetes is going to 3/4 of those patients get heart disease, of type 2 diabetes get heart disease, and also increases your risk of arthritis and certain cancers. Such as breast cancer and so forth. So for all of these reasons, we don't want women putting on weight. So that's one of the reasons we would do that. We will focus on cholesterol, make sure their cholesterol is normal, try them healthy eating, see if that comes back normal. Some people do have a genetic, what we call an LDL, hyperlipidemia, and they may need a statin, but we'll always try them with diet first, see how they get on. But obviously if they have a very high LDL, which is the bad cholesterol, which is going to attack the arteries, lay down plaque in your coronaries and in arteries to the brain, then of course they are going to need a low dose statin to bring down the cholesterol. And I think the big thing is when patients go on a statin, they need to be told you're on it for life. You can't just go on it for a month and come off it again, because we have to keep it normal, to keep the arteries normal for the next 46 years. I think that's the big thing we have to do as medics, is to communicate about the compliance, and that you must stay on it once you put on it. It's like a blood pressure medication. If you go on it, you stay on it for life. That's the key.
And
yeah, Catriona, I was going to ask you.
And I would say, just to be a bit more specific about the healthy eating, I noticed we've got Aisling on the call here, who is obviously a dietitian. Yeah.
Oh, well, then Aisling, we'll let you take over. Sorry.
Aisling's one of our background issues this evening.
I don't know what Aisling's role is in the webinar, but I'm sure she'll correct me if I'm wrong. But I mean, it's things like really eating plenty of fruit and vegetables, especially vegetables, and eating fish and choosing maybe white meat and fish over red meat and processed meats. moderating alcohol intake, and I suppose healthy carbohydrates, whole grains, and pulses. So it's just to be when I say pulses, I mean, you know, things like beans, so butter beans, chickpeas, and those foods. So I'm sure, I don't know, as I said, I don't know what Aisling, is Aisling messaging, or is she
We'll
doing
probably be, she's in the background answering some questions with the backroom team this evening, yes. So Eva, can I just come to you and ask you what you're seeing in terms of risk factor management in your practice? You know, are people presenting with blood pressure on controlled hypertension? Are they managing that? Are they aware of that when they come in? Do they realize what a risk factor that is? Am I right in saying that is a significant risk factor?
Yeah, so the blood pressure is certainly something that's there. So what, you know, we really like to get is the 24-hour blood pressure monitor. So I can really have a good look at how the lady's blood pressure is over a 24-hour period. And, you know, sometimes women are surprised to see that, oh, yes, it is raised, and that now we need to look at this and pursue it further, and, you know, to treat it, again, because it's such a strong risk factor for heart disease and stroke. And then, you know, that links back then to the, you know, when I inquire more about their diets, it can be, you know, quite a processed intake of food. So I know maybe getting back to the healthy diet again. So it's the re-education about, you know, what we're trying to look at. So managing the blood pressure, possibly starting antihypertensives or blood pressure medication, and then, you know, really making healthy choices around your foods. And then the other thing too is the stress that this female is often under, you know, with her work, with, you know, family, trying to keep everything, the show on the road, and then also internally how she's feeling, you know, and this too can contribute as a risk factor itself for heart disease, but also affecting the blood pressure. So this all, you know, ties in together. And so, you know, when we look at the risk, trying to find the risk factors for heart disease, manage them, you know, a lot of them are going to tie into, you know, how does a woman take care of herself at this stage of her life? So it's really about like looking at, you know, what am I doing for myself in terms of the food choices, looking after my weight, looking after my stress levels, seeing how I am in terms of my blood pressure, my cholesterol levels, and then also looking at, you know, at the alcohol intake, what's happening there. Sometimes we lie to ourselves and realize that there's a lot more intake than what's acceptable with the WHO guidelines.
Yeah, that particularly happened in the COVID pandemic, obviously, didn't it?
For sure. And then again, you know, those liquid calories, they're hidden to some degrees. You might just think, oh, it's just another glass of wine, it's okay. But this is what really adds to, you know, that, you know, the extra weight that comes on in the middle area, and it increases your risk of diabetes. And once the metabolism slows down in menopause, it's harder to lose it. That's why Mary spoke so well about really looking at, okay, what are the healthy food choices that we can really initiate for the family and maintain? And that's realistic without being purgatory.
Yes, exactly.
And also physical activity. So, you know, pairing that, you know, with being physically active. And one of the biggest things that's coming out in the evidence about physical activity now is reducing sitting time. So being conscious of how much time you spend sitting. And, you know, it's not just about going to the gym once a week or twice a week or even every day for an hour. It's really about being active and taking the opportunities you have to be active. So walk somewhere instead of
exactly.
You know,
and the Ashley just put up a link there to the Mediterranean diet, and I think the Croí, you have a link there, Annie, as well. But the Mediterranean diet, Professor Roseanne Kenny brought out a book called Age Proof, as you know,
Yes.
and there's a lot of proof in the Tilda study that the Mediterranean diet actually improves, you know, longevity, which is of course what we want, but of course it is very helpful for women as well. But there's a link to it anyway, to the Mediterranean diet and what to eat. So Aisling has just put that up there. So that's good.
And a lot of the questions that we've gotten in advance of this webinar was from women who were saying, you know, that they're in the throes of every single symptom imaginable in terms of menopause, and then thinking in terms of signs and symptoms maybe of heart disease, and trying to navigate that and know what they should be really worried about or what not. So that's where it comes in terms of linking in with your healthcare professional,
Absolutely.
Understanding where you are, knowing your own numbers.
Yeah, absolutely.
Yeah,
That's it. And I think
just...
a history is key, and you know, go to their own GP and who will take a good history, and then they will be able to determine, you know, how much of it is menopause, and they'll obviously do an ECG as well and just check their over and heart health as well. And as you said, make sure the blood pressure is normal, go through the diet, make sure the cholesterol is normal. You know, somebody said, how do you check for metabolic syndrome? It's just, you know, it's low bad cholesterol, it's you know, the HDL levels are very low, high LDL, sorry, blood pressure can be high, and you know that they're the key features of abdominal obesity, your low HDL, which is good cholesterol, and very high bad cholesterol. That's the key for metabolic syndrome, just answering the question that came in there. But yeah, so if somebody presents a really good history, we've all been taught that in medical school, that's good. That will determine, you know, how good the heart is. You do an ECG, and then obviously you'll do an examination and you'll do all the bloods. So that would be the key. And then obviously then you go for treatment. In terms of, you will always talk about losing weight. Somebody said there she'd put on 2 stone, it came through in a message there, and really you just have to go and get the diet healthily, get out exercising. Now I want to say something about exercising. When people are exhausted, you don't want them exercising too much, because that's when they make that pituitary gland tireder. So it's about not overdoing the exercise. So the key thing is focus on the diet. And while exercise is important, when you're very tired, you're not sleeping at night, which happens a lot in menopause, you can't be running the road. So you're only going to make yourself tireder. So it's about really concentrating on diet, and yes, do exercise, but don't overdo it. So it's about getting a balance.
And actually, it's more about being physically active rather than necessarily thinking about exercise, but being active. Yeah, exactly.
Yeah.
Just while you're on that there, Mary, you were talking about the pituitary gland. It's about hormones and the science of endocrinology. I suppose they're a fundamental element of who we are. And can I ask you to explain a little bit more in relation to menopause, your cardiovascular system, and generally how when things change and there's an imbalance that we actually feel it physically?
Okay, so when we get low estrogen, and so what happens in the menopause is our eggs decline. The FSH hormone from the pituitary that pushes the ovaries to produce, that basically goes way up. So once that goes way up, we've got a knock-on effect at every nerve muscle junction. So that's why we all get aches and pains in the muscles as a result of that menopause when FSH goes up. And it should be a lovely physiological.
FSH, Mary, is
FSH is our follicular stimulating hormone. So that's the hormone at puberty that pushes the ovaries to produce eggs, and it also, you know, helps egg maturation. And then LH is the hormone that causes ovulation. Okay, so when eggs become depleted, and they start depleting from the age of 45 to 50 usually, which is perimenopause, when you notice the periods getting a little heavier. But at menopause is when periods cease, and that's when the FSH levels go up, estrogen levels go down, and then as a result, when that happens, you often get a raise in your LDL, which is your bad cholesterol. That affects your heart. You get a lower estrogen level, and you can also get hypertension because of the fact that you're putting on weight. That can be, and also your arteries can become stiffer as a result of the reduced elasticity because of the low estrogen. So all of those factors can cause a higher blood pressure as well. So with that's really what puts women at risk, is the fact that they've your metabolic rate is going down, your metabolism is slowing, you're tired, you're not sleeping. So again, that's affecting your metabolism. And then also you might be putting on weight. And on top of that, then the LDL might be rising, and it'll rise even more if there's a genetic reason for that. And obviously, what we do in that case is, as well as taking the history, you treatment, and there's a question about HRT.
Yes.
So
we'll come on to that now. Actually, we might as well.
Okay,
Yeah, come on to that. Yeah,
so
I think it's probably going to take up a lot of our conversation.
Sorry, okay.
But yeah, no, you're okay. I was going to say we'll come on to that
so
now.
obviously
Yeah,
the big thing is prevention, and we talk about diet, we talk about exercise, and then the Mediterranean diet is certainly, and hydration is very important as well. Hydration is very important as well. Yeah, absolutely.
I heard you speak, Mary, somewhere recently about water, about drinking. You were talking about drinking
2 liters a day. So 2 liters a day is what we should do, and in the morning, because the research is showing that we should be taking this more in the morning, because it helps with the bowel muscle. People forget that hormones control all muscles. So we're all skeletons covered in muscles. So that pituitary gland controls all muscles, including bowel muscle. So a lot of the reason why women have IBS around this time is because the circadian rhythm is off, and that's why you get bloating, passing wind, belching. But water is very important, but particularly in the morning, to front load, because your bowel needs it for that conveyor belt and that circadian rhythm. So it's very important, and a lot of women don't, because they're so busy looking after everybody else, but they really have to do it then, and not before you go to bed, because you're going to disrupt an already sleep cycle that's affected as a result. But the sleep is one big thing for women, because when the hormones are off, it affects deep muscle relaxation. People get peripheral nerve pain, restless legs, which is a form of peripheral neuropathy, and that's a big symptom that women suffer, and that affects your sleep. So your muscles aren't going into deep relaxation, and therefore you only get a 2-hour deep sleep, and the rest is surface sleep, which is no good. And that's why women are exhausted. And of course, that makes the pituitary gland tireder and exacerbates everything. So that and exacerbates your sweating and your flushing as well, because your adrenal glands are affected as a result of that. So the whole thing is a vicious circle. So it's not easy being a woman.
It really is not. It really is not.
No.
So can I ask Eva? Can we get your thoughts? Let's say on HRT. Are you prescribing HRT in your clinic? What are your thoughts on it? There's a lot of questions from a lot of people about it. Whether they'll consider, whether they'll take it, whether they won't. They're talking to their friends. People have different experiences. What are your thoughts? So in practice, what are you doing?
Okay, so and to link in with what Mary said there, that okay, we can see that there is difficulty here in the menopause. There's a lot of difficult, challenging symptoms, but it is for the woman not to lose hope, right? There is good help, and there's lots of good treatment plans for her. So when I come back to practice and to the females that come in to me, I'm going through what is the most suitable option for her. And HRT does come in for a lot of cases, and finding the right plan for her. So there's lots of different types of HRT, between tablets, patches, gels, sprays, intrauterine devices. Okay, and it's a combination to find the safest one for her. And before before the medication side of it, or the pharmacological input, there is all of the lifestyle changes that we spoke about, because this is what builds well-being, that I am choosing to take care of myself and to make these changes that aren't easy. We know that they're not easy, but it's about making a commitment to yourself. And then with that, I can marry in then the hormonal replacement therapy, and what is safe for the woman, and always reviewing, to make sure that she's progressing on it, doing well, and always keeping an eye out for any risks that may change things and maybe change what we're deciding.
Excellent, thank you. Yeah, and just before we move over to Mary, and maybe Mary might have something to say about this as well. Just as I was listening to RTE this afternoon, and there was a big conversation. I presume you're aware of that, with the shortages and all of that kind of thing. I'm sure you guys are very well versed in that. I didn't realise that it was as bad as it was. I don't know if you have anything to say about that, or if you can say anything about that. The problem is the supply chain, it sounds like.
Supply chain. So I had some patients this afternoon that I was trying to work through that with, where they can't get the particular estrogen patch that they're used to. Then there is an alternative, but it's slightly bigger. It's the same medication that it gives, but some women are maybe noticing different effects from it. But there are other options, okay? It's not that this is going to be not available forever. So there are some other options there too, in the line of gels and sprays that deliver the estrogen. So those estrogens are all given, those ones between the patch and the gel, the spray, are given through the skin, which is a very nice way of delivering estrogen, and a safer way for a woman who may have extra weight on, be it overweight or obese. So you have a lower risk of a blood clot. So that's a really nice way of delivering estrogen in a safe way for the woman.
Excellent. Okay. And Mary, do you have some thoughts on this?
No, I would concur with Eva said, that we are, because of the evidence-based medicine, we're actually switching over a lot to the gels, transdermal, because, you know, the patients are getting less amount, but yet it's equally efficacious than the tablet. So we are moving over to that. Some people have a preference for the patch, others have a preference for the gel. You know, the big thing is that, as you know, anyone that has a womb, they need progesterone with it, and if they're without a womb, they don't need the progesterone. So I think people are very well versed. The big thing, I suppose, is there's a lot of misinformation about HRT. So we as doctors are put under pressure to give HRT where people might have a family history of breast cancer, and there's some social media saying that it's safe. You can only give it if the patient, if the mother, so if the first degree relative, the mother or the sister, had breast cancer. If that breast cancer wasn't estrogen dependent, then you could consider it. But if there is an estrogen dependent breast cancer in the family, then you would not prescribe HRT. And so social media would argue with us, but we're based on evidence-based medicine, so that's what we follow. Exactly. So it's important to say that. So that would be the big thing that I would say. Not everyone needs HRT. Again, there's sort of you know, a big push on HRT. I would be very, I'm sure Eve is the very same, that, you know, if the patient wants it, we will discuss it and see if it's suitable for them, and if it is, then great. There is a time when, you know, again, evidence-based would say that we should stop it at 60, because after that it can, while it's the jury is out, but we were always taught it was healthy for the heart. There is some studies saying maybe not, but at the moment we are basing that it's good for the heart up to the age of 60, but after the age of 60, it's not, evidence-based would say we have to stop it. Now, there are some patients that when you stop it, they absolutely suffer. So you have to deal with that on a named patient basis. And some patients you have to leave it on it. And remember, some patients are very unlucky, and that a lot of menopausal symptoms will abate at 60 and even at 55. Some get a recurrence in their 70s. And then, you know, they would be suffering so severely that you might have to consider reintroducing HRT at that stage. So every patient has to be dealt with on an individual basis. But for the most part,
I was just going to say, this might seem like a stupid question, but if you've had you know, very significant symptoms, and you're now on HRT and your symptoms have abated and all the rest of it, that doesn't mask the real symptoms of which are similar in some ways for women in terms of a heart attack or something like that. It doesn't, does it?
No, it doesn't, but that's a very good question. So I suppose, you know, no, the big thing, so yeah, in fact, if anything, well, it wouldn't, no, and that's a brilliant question, actually. If anything, if women are terrible sweating and flushing, the HRT tends to deal with that. And if they're still fatigued, you're going to look and see, why are they still fatigued? You know, I think that's the big thing. The big thing, I think, is that the HRT is fantastic for helping with sweating and flushing. It's not very good for dealing with the lack of sleep and the peripheral nerve pain in some cases. And that's where we have to use other things to treat that, because it's really important that the patient is getting sleep. You know, it really is. If you've, you know, if you're not sleeping, for all of us, it's detrimental. Yeah. And it's been shown in all the studies that we do need to recharge, particularly the pituitary gland needs to recharge. So that's something. But HRT works very, very well for the flushing and sweating on all the autonomic symptoms. But, and obviously the memory and the brain fog, but for the peripheral nerve pain and the restless legs, it wouldn't, and you do need other medication for that. But the good thing is that we're putting it all out there, and patients now know what to come and when to seek help. Yes, and I forgot to mention supplements just while we're on it. You know, there's a lot of supplements out there that are very good, that have omega-3, natural phytoestrogens, you know, high vitamin D, which is good for bone health, biotin for the hair. So it's a lot of supplements which are very good as well. So we should also mention those. Yeah.
And can I ask one other question? Oh, sorry, Eva, go on.
I just wanted to mention just one other subgroup of symptoms that really affects women in menopause, and it hasn't come up in conversation yet. So, and again, it's something where the woman suffers in silence and just seems to put up with this. But you know, dryness in the vaginal area. Okay,
yeah, absolutely.
That can
we've got some questions on that. Yeah.
Real discomfort, irritation. It can give rise to recurrent urinary tract infections or recurrent feelings of cystitis. And then in terms of their partner or husband, you know, it can cause painful intercourse, okay? So in a no-go area. But then the other caveat to that and outside of that is that with the menopause, there can be reduced libido, and it can affect things a lot. So again, with the treatment, you know, there are, you know, lubricants available, but also with the use of the estrogen, this is something that can really help those symptoms and really change a woman's quality of life.
And those estrogen pesticides have been shown to be very safe in a huge trial, Eva, as well, very safe and not causing any cancers. So that's very reassuring. They're brilliant. And we're now using, if people have very low libido, we're now using some low dose testosterone as well, and that's been shown to be very good and not have any side effects like hair and acne, which is great as well.
And it can give a woman a real a pick me up and a new revived energy. Okay.
Exactly.
That's great information, guys. Thank you. And just on HRT there as well, we've had a couple of questions asking about taking other medications at the same time. Is there any contraindications there? You know, like blood pressure medication, cholesterol medication, that kind of thing. Is there any reason why you wouldn't take anything else? It's safe as long as you're in consultation with your GP and your consultant.
As long as we've like, so this is all, when we're going to start the prescription of a HRT, we'll do a full risk and benefit analysis and really get a good picture for what the lady's on. So if she's already on, you know, cardiovascular medication, that's not a no-no for HRT. Okay. I mean, there are certain, you know, areas that no, she cannot be on HRT. So if she has an active breast cancer, that's obvious, has to be stopped. You know, you know, and so that's one. I was going to talk about a case, but I won't. But so that's something. So if she's breast cancer, has to be stopped. Or if there's a new breast lump, we don't know what it is. No HRT until we know what it is. Okay. Yeah, Mary, do you want to add anything to that so I'm not missing?
No, you do. Wait, what the question, Annie? Sorry,
so people, that's okay. People, there were a couple of ones in there. So there was one specifically regarding other medications like blood pressure medication, cholesterol medication. Can you safely take that while you're on HRT?
Totally, absolutely, they would, and a lot would be on the combination. Yeah, absolutely, it wouldn't interfere at all. No, absolutely not. The one thing that patients, if they're overweight, you know, and they sweat a lot, the patch mightn't be suitable, you know. So these are things, but no, they all certainly cholesterol medication, heart medication would be safe. Yeah.
And on the cholesterol thing as well, there was one question from someone asking, does HRT, and I can't remember, you maybe have mentioned it, Mary, lower cholesterol or lower the bad cholesterol? Or is there any evidence for that?
No, HRT doesn't. I mean, it helps with the elasticity of the arteries. And again, there's research now saying that it mightn't be as beneficial as we once thought, but certainly the HRT, all estrogen will help with reducing elasticities and helping with stop that stiffness of the arteries. That's actually what causes the high blood pressure, is you get stiffness of the arteries, and that, you know, actually disimproves as you go on. So there's evidence to show that is the case. Where the jury is out as to how protective estrogen is. There's a new trial, and we were talking about Catriona earlier, you know, saying that it mightn't be as beneficial as we once thought. But I suppose the big thing is that we're trying to give patients better quality of care, better quality of life. So we're taking the holistic view here, and we're saying HRT definitely helps with the terrible autonomic system, you know, symptoms, the flushing and the sweating, the brain fog. Patients patients have more energy with it. And it helps with the vaginal dryness that Ava was saying, and also you can add in the pessary. So there's great benefits in that sense if the patient needs it. We're not saying it's for everyone, absolutely not. Some patients don't need it at all, and certainly don't even want to go on it. And some patients then might just have the peripheral nerve symptoms and restless legs, and they will go on other medications. So I think the big thing with menopause, I think, is we have to view it as a holistic way. So we look at the HRT. If they need it, we treat the heart health, which is really important. We treat the bone health, and we also focus on a woman empowering herself and loving herself, and actually pacing and resting that pituitary gland, because women are very poor at doing that, and saying no and putting up the boundaries and raising her self-esteem. Because all of this is a time when you can actually approach that, because if women do that, then everything is going to work much better. You're going to get a healthier hormonal system as a result of that. So I think the holistic view is the way to go about menopause, really. And it's improve health, yeah.
Yeah, and I was thinking also, I'm thinking about especially, the lack of sleep, and how that can really have a very bad impact on your psychological well-being, as well as obviously other things. And that's quite a difficult one, but I think I'm thinking of alternative therapies like yoga and like learning relaxation techniques. These are all, and there's apps, out there to help with relaxation and promoting sleep. And I mean, I really think that it is very, very important. So it's not just about getting sleeping medications to help you sleep, but it's actually more about looking after yourself and looking at things like yoga, which may really help you to focus on yourself in a different way.
Absolutely. Thank you, guys. I think we've pretty much covered most things there. Is there anything in the chat, guys, that we need to address? And I'm just looking here. We had another question, just a general question around women and other conditions, and heart disease. And then when they're arriving in menopause, let's say people with rheumatic fever, preeclampsia in pregnancy previously, rheumatoid arthritis, that kind of thing. Are you seeing those people in your practice, Eva and Mary, now that years ago would have maybe gone through that or suffered, lived with that for years and have gone through menopause, and maybe they didn't have the intervention, or maybe they didn't have the education at the time?
Yes,
is there a cohort of people out there now that need help in that regard?
And so they've gone through the menopause and now they're postmenopausal?
Postmenopausal, yeah. Or going through the menopause, I suppose, having lived with the conditions like that for a long time.
I mean, that group will be there with lots of all the other comorbidities. With that case, again, it's like treating each woman individually, okay? So the HRT won't be for every woman, it'll be for a lot of women, but it's about educating her and seeing what her needs are and how I can meet them with the treatment, okay? But then, going back to the outset of our talk this evening, coming back to looking at risk factors and how can we modify them, and what lifestyle changes can we realistically make.
Yeah, absolutely.
And all autoimmune disease is more common in women, particularly at this time, because the immune system isn't as healthy when people get overtired. So we see more thyroid disease. We see, rheumatoid is an autoimmune disease as well. So again, sort of, getting women to look after themselves more, it means a more healthier hormonal system, which actually controls your immune system and puts you at less risk of autoimmune disease. That's really important, because that's why thyroid disease is more common in women, particularly, when they get overtired, coming up to menopause or through menopause, we see it quite a lot. So this will be very beneficial.
I'm just looking here. There was one question. I would love to hear the panel discuss HRT following MI and insertion of coronary stents. Is it safe to continue HRT as I've been on it for years? I guess you've probably answered that question already.
Yeah, so I mean, I would have patients with that background, and again, I'll see her again, weigh up the risks and the benefits, but it is still safe to prescribe and to take the HRT, you know, because that lady will be really motivated. She doesn't want a recurrence of her MI.
And it's transdermal that we use there, isn't it, Eva? Yeah. And you'd also speak to the cardiologist and make sure that they're all happy and make sure she's on all preventative statins and so forth. Yeah.
There's a really good question here, actually. Should cardiovascular screening for women over 50 years be rolled out similar to breast cancer and cervical screening nationally? Very interesting discussion.
Interesting question. Well, you know,
I'm sorry. Could you just repeat that question? Should cardiovascular
basically, should cardiovascular screening for women over 50 be rolled out similar to breast cancer screening or cervical screening? In the same way?
Well, I think it would be amazing if it could, but what I can add that's maybe the next best thing, but it's not quite the same thing, but we have now in general practice is the chronic disease management program. So for the patients that are you know, over 65, we're now looking for them to see opportunistically if they have the risk factors. So that is a program that's happening in general practice. But again, it's for the group over 65. And if they have established heart disease, you know, we're monitoring them from whatever age that comes in at, be it before 50, before 65, after 65, if that makes sense.
And I suppose for women as well, the cardiovascular investigations we do, the stress test can not be the best in women because it can false positives and false negatives. So the CT calcium score is probably the best screening for women if you were doing it. And that sort of gives you an idea of how much plaque they would have. So that would be the best test to do.
And I would have thought it would make sense to reduce the age of that screening, Eva. I don't know what you think, but you know.
Yeah, it would. Yeah, definitely. Yeah.
Yeah.
It would. And hopefully that will happen with time, but that's what we have right now as a system. But of course, like, you know, that's what we're doing in GP. We need to be looking out for that.
And that's very positive that's introduced. Yeah, that's fantastic. So guys, we're coming up to time here, and definitely, as I said at the start, there's absolutely another webinar in this. Can I just before we finish ask you for some final thoughts or final messages, take-home messages that you'd like to leave us with this evening? So Catriona, will we start with you?
Yes, well, I would say that it's a real priority for women, and not just waiting for the menopause either, actually throughout your life. Women think, oh, I'm not at risk of heart disease in the same way as men, but actually they are. And they really need to look after themselves and look after those lifestyles, avoid smoking, eat a healthy cardioprotective diet, and stay physically active, and maintain or lose weight, and maintain a good healthy weight and shape.
Eva, do you want to go next?
So what I will say for anybody who is you know, concerned about menopause and of course their heart health, come to your GP. There's a lot of good GPs out there that have really been trained up in menopause care. Maybe not every GP, but there is a good team across the country. So make that time for yourself and make sure you get checked and seen and helped.
Thank you, Eva. And Mary?
So I think it's wonderful. We've come so far in the last 7 years talking about menopause. It was a real taboo subject, and now we've made it just, you know, a conversation piece around the table, which is wonderful. What we're now aiming to do is to let women realize that, you know, heart disease, they're six times more likely to get a heart attack than breast cancer. So we have to educate the public and educate women. I think it's wonderful that we're talking menopause, and while we're talking menopause, let's also look at the other systems like heart, which we're doing today, bone health, you know, and you know, a libido and sexual health. Look at all of that when we're talking menopause. But the lovely thing and the tip I want to leave is that it's empowering to see that women are coming to equality, that, you know, menopause has been around since Adam and Eve, but finally we're recognizing it, which is wonderful. And that we're now, it's a time for women to pause in their lives and and say, this is my second chapter, I'm going to love myself. And in that, we're going to look at, you know, good health, and not just menopausal symptoms, but heart health in particular as well, because as we said, 6 times more commonly will you get heart disease than breast cancer. So look at that, look at your bone health, look at your overall health, and look at your boundaries, and increase your self-esteem, and look forward to the next 46 years, hopefully. That's
Excellent.
the key
I love it.
message.
So thank you very, very much, guys. We really appreciate your expertise and your input this evening. And I'm sure everybody has found it really, really helpful. And for our audience, this has been recorded, and will be available on our website from tomorrow. And anybody who attended will get an email as well with the recording attached. One final thought, actually, maybe, will we ever have a Minister for Women's Health in Ireland?
Fabulous, wouldn't it be fabulous?
Yeah.
Yes, we could well. But we'll then get the thing about where we'll say that men will say that they're being left behind. But yeah, we were left behind for years.
For long enough, yes.
I don't think I'll say I'll take that. Yes, wouldn't it be fabulous? Wouldn't it be fabulous?
Absolutely. Okay. So with that, we're going to sign off for this evening. Just to let you know that, as I said, the webinar is recorded, so you will get that. You will also get in the email a little survey that we would be really grateful if you would complete, a Survey Monkey, just on how the webinar went and ideas that you'd like to see for other webinars in the future. Our next, sorry, actually, before I go on to that, I should say, and Bridget, you might have a slide to share there. Yeah, thank you very much. Just any questions or queries that you might have with regard to any of the topics that came up here this evening. In the background, the Croí team were answering questions, and thank you very much to my colleagues, Maeve, Bridget, Aisling, Josephine, Madeline, all working away in the background. Maeve, our nurse who manages the HeartLink West helpline, will be available from Monday to Friday, 9 to 5:30. You can call 091 544 310 if you want to call and follow up on any of the questions or queries or anything that strikes you later on in the week. Just give Maeve a call and you can have a chat, and she'll be able to direct you to the different services that we have and otherwise that may be of interest to you. And the other thing then to say is that we will be hosting our next webinar on the 28th of April. So stay tuned for information and registration details on that. Managing your high blood pressure, that's always a very popular webinar. So that will be with another panel of wonderful experts on Thursday, the 28th of April. Times and speakers to be confirmed. So thank you very much, everybody. Have a lovely evening. There's still a little bit of sunlight left, so hope everybody get out to have a nice walk and to put into practice some of the things that we've learned here this evening. And again, thank you so much to our speakers. We really